Great. It's a pleasure to be here today. And, it's really been an interesting journey. We started Garden Health about 10 years ago, and really with this vision of really transforming cancer care. And what we saw was a field that was very data-starved, and that was really the biggest challenge. And we had this crazy mission of trying to conquer cancer with data, data really being the operative word. And why is that? So let's delve into three different areas of cancer care. The first one is the one that I think the panel before really focused on, which is early detection. We all know that if we can detect cancer early, many of them can be either cured or have much better survival rates. With active cancer, metastatic disease, late-stage disease, the big challenge is how do we match these patients to the best possible drugs? The tumor, just like COVID, is evolving, it's changing, it's evading therapies. And so it's not just finding the right drug the first time, but staying one step ahead of the disease and following it and tracking it with next-generation therapies. And then finally, in the post-cancer setting with cancer survivors, really thinking about monitoring for recurrence, finding it as early as possible, and treating it as soon as it rears its ugly head, and giving those patients what we call peace of mind or quantitative peace of mind. And the common thread here when we first started in this space was really the ability to measure and track the disease quantitatively, really staying one step ahead. And the challenge is we're often so blindsided by cancer. It's why it continues to be a scourge on society. So I come from the tech field, and I'm a student of semiconductors and some of these fields that we're all aware of. We look at batteries and electrical vehicles and so on. We see the extraordinary rate of progress. There was essentially a gentleman by the name of Douglas Engelbart who invented the computer mouse in the 50s. And he was also a student of technology, and he realized that progress in almost any field can be essentially measured by this equation. It's basically the rate of progress is exponentially proportional to the data acquisition rate and how well we network that data together. And so our thesis was if we could change the rate of data acquisition in cancer, we could get exponential gains in terms of our progress there. And we all know the most famous example of Engelbart's law, which is Moore's law, but this has been standard power law in almost every field that has changed the way that human society has worked for the last few decades and more. So what happens when time constants change? Well, all aware of these examples. So, how long did it take to get to 100 million users? With a telephone, it took 75 years. With a mobile phone, 16 years. Facebook, 4.5 years. And Instagram, 2.3 years. And so we know that when we change these inertial barriers, when we have these platform shifts, we get exponential gains. So how do we do that in oncology? How do we change time constants? The thesis we had 10 years ago was tissue biopsies, the fact that the genomic information, the molecular information for solid tumor cancers is really embedded in tissue somewhere in the body. That's why we're blindsided by it, we can't track it, and it's very difficult to gain information about how the tumor is evolving and changing over time. If we could access that same information comprehensively through blood, that would be an enormous change. It would essentially change the time constant in that exponent in terms of data acquisition. And that's exactly what is happening. We launched the world's first comprehensive liquid biopsy in 2014. Since then, we've tested and helped over 300,000 patients. Almost every oncologist in the US and many globally have ordered it. And we're doubling the rate of testing every 18 months, a sort of Moore's law in some ways. And with this data, though, what have we been able to do? The thesis behind the company was, let's start with late-stage disease, really understand what stage 3, stage 4 disease looks like in the blood, and then move backwards towards early detection. And the goal was a simple blood test at an annual physical for the early detection of cancer. And so this year in 2022, I'm happy to announce that we launched our first liquid biopsy for screening, Shield, and we've seen the uptake has just been fantastic. We've seen really fast uptake, really fast adoption. over 90% compliance and adherence. And we've seen that this test, this is initially for colorectal cancer, is producing about 90% sensitivity for early stage disease. So on par with a lot of the other methods that are out there for screening, which is important when you think about it from a health population point of view. And this test not only looks at DNA changes, it looks at methylation changes, structural changes in the DNA, at proteomics. And so we've taken a very multimodal approach to be able to get to this high sensitivity threshold and this high sensitivity bar. And so if we look at where we're playing in the cancer continuum right now, we have Shield and early detection that can hopefully help billions of individuals around the world. We have a test for Garden Reveal, for cancer survivors, Garden Reveal, which we launched last year. And that is essentially helping hundreds of millions of patients with essentially recurrence monitoring. And finally, the first test that we launched, Garden 360, hopefully can help the 10 million cancer patients around the world with better therapy selection and monitoring. I want to just share a patient story, because these things, often, can be very dry without being put into perspective in terms of the patients that they're helping. This is a patient we helped last year, a 28-year-old woman who was diagnosed with stage 4 lung cancer. So very young to be diagnosed with such a serious disease. She was actually pregnant with twins at the time, was put on chemotherapy, but that wasn't necessarily the right option. So she had a blood test, one of our blood tests, and we found there was a ALK fusion that was driving her disease, a pretty potent mutation that has a targeted therapy that's associated with it. So she was quickly cycled to that targeted therapy, had an amazing response, was able to deliver those twins. They were healthy. And then her cancer came back, and she had another test. And essentially, we were able to see that there was a resistance mutation, just like with COVID and the evolution that happens in diseases of all types. This happens with cancer. And she essentially was able to be matched to a second generation, third generation ALK inhibitor, and had a fantastic response once again. And so this is really showing this culmination, this fruition of this idea of adaptive management of disease, coming in, staying one step ahead, and being able to give patients like her essentially a high-quality life and time with her kids and loved ones. So, I think the panel before this, I think hit on some pretty important, issues. When we think about going from technology to helping patients, like the one I just described, it's all about access. And it's often not the technology that's the biggest impediment. Sure, the technology is difficult. We've spent billions of dollars developing it, and many other companies are also in this space, developing fantastic breakthroughs. But it's often about access. These tests have to be paid for by the public system. There's a very small appetite for individuals to pay out of pocket for even important healthcare information or healthcare treatments. And then the second is the modality of access. What we found is by moving to a blood test rather than a tissue biopsy, by moving to a blood test from a stool test or colonoscopy, or when you think about lung screening and low-dose CT scans, there's been fantastic trials, evidence that has shown that lung cancer screening saves lives. Yet in the United States, compliance is 6 to 10%. And it's the same thing globally. Compliance is very low. It's hard to get access to a radiology site, do the CT scans, go through that protocol. And that's really where a blood test can make a huge difference. Blood is the lingua franca of the modern medicine field. And so being able to integrate that with how we do all of our other blood tests, how we get all the other information out there, is going to be a game changer. And so these tests have to be paid for, but I do believe blood is going to play a very central role in terms of ensuring that no patient gets left behind. So what's next in terms of what we're working on here? So one thing I'm really fascinated about is, obviously I worked previously in the field of genomics, was instrumental in helping develop tools for DNA sequencing. And, Europe and, the global effort around the Human Genome Project was a fantastic human achievement. And, you look at the body, you look at the human biology that makes us up. There are about 37 trillion cells in the human body, and they all have that same genome largely. And so once you've seen one, you've seen them all. And so I would argue that genomics is a little bit overrated. When you think about human disease, it's important from rare disease, important from cancer, but very few diseases have a genomic or genetic footprint in actuality. And so you look at these two mice, they're genetically identical. They have the same genomes, you can sequence them, same letters. Yet one is obese and one is thin. And so what's different about them? It's their epigenomes. It's really the switches that turn off and on each gene. Think about the 37 trillion cells in your body. You have heart cells, liver cells, skin cells, eye cells. They're all vastly different, yet they have the same genome. And so you would be blind to any of those differences. It's the same thing with disease, in general. And it's pretty interesting, just the epigenetic footprint that is there for almost every disease, from cardiovascular disease, neurodegenerative disease, diabetes, even things like diet and exercise and so on, can essentially leave a fingerprint in the epigenome. So why hasn't this been explored in depth? It has been explored by various members of the scientific community, but we really haven't had the technology to explore it in the same way that we have had with the genome. It's been bulky, it's been this laborious process called bisulfite sequencing that's just not amenable to the same type of exploration we've done on the genomic side and the genetic side. And so, in our pursuit of early detection, we developed new technologies for looking at the epigenome broadly. And so I would argue, once again, you can tell my sort of technology side of the thing. So when we brought in the first liquid biopsy, first comprehensive liquid biopsy, we made this analogy. This was very similar to moving from landlines to cellular phones. And that has kind of borne out in terms of the ease of use, the speed, and so on. And so when we look at where we're going, we believe that the next wave of technologies will be akin to the smartphone, where the phone became the least important feature of that smart device. And then this essentially allowed us to develop countless applications on that platform. And so just like in 2014 when we launched liquid biopsy and this field really emerged, we have a new test coming out, this smart liquid biopsy called Garden Infinity, that essentially we believe is going to unleash this age of the epigenome, really looking comprehensively across the genome at all the signals on the epigenome level at low cost so that we can essentially see all of those signals. And I would argue that the first application is early cancer detection, which is the simplest application. It's a binary result, do I have cancer or not? But I think what's going to be really interesting is when we start interpreting these signals and really correlating them to thinking about organ health, thinking about where disease is coming from, cardiovascular disease, neurodegenerative disease, and essentially bringing this paradigm of precision medicine, which in oncology really has been the canary in the coal mine when we think about that precision medicine paradigm. We've gone from therapy selection, MRD, screening, and oncology, and I believe with the power of epigenomics, we can bring this model of personalized medicine, precision medicine, to almost every other disease area and see the same type of revolution over the next 10 to 15 years. So thank you. I guess if there's...
Okay, so that was fascinating, frankly. My head is hurting a little bit after just the sheer scope of where that could go. We do have the opportunity, thank you for that, we do have the opportunity for a couple of questions before we take a break. So we've got one over the side here.
That was a really great presentation. I'm interested, some of the tests you sell at the moment, they just do ctDNA, and some of them are using DNA and proteomics. What's the difference? Why do you need it for some and not for other? Is it to do with the shedding?
That's a great question. So what we
I
found,
thought so too.
what we found was essentially the genomics is great from a specificity from late stage disease. As we start going, methylation helps with much earlier disease, broader type of payload. We found that proteomics helps with sort of the precancer. So thinking about early adenomas, some of the precancer signals that are there, they may be with some of the inflammatory response. And so each one sheds a different light in terms of the underlying disease.
So does that mean you're going to have an advantage over Grail?
Yeah, they used to work for me, a lot of those people, when I was at Illumina. So, we think we're doing very different things. We're developing a technology that has high sensitivity for early stage cancer, so 80-90% sensitivity for stage 1. A lot of these tests that are multi-cancer are like 15 to 20% sensitivity for stage 1. So they do many cancers, but we think in terms of actually replacing some of the standard screening methodology, which have low compliance, fit testing, low dose CTs, and so on, you have to hit the bar in terms of higher sensitivity for early stage disease. That's how we bend mortality curves. We're not going to bend mortality curves by only finding stage 4 disease. And that's the difference in terms of what we've been focusing on.
Ben Westphalen, University of Munich. Thanks for the great talk. So I have a question. You mentioned that reimbursement has been challenging for all these testings.
Yeah.
Now, with epigenomics, you move even further away from a realm of evidence-based medicine. How do you envision models to get reimbursement for these transforming techniques?
Yeah, that's a great question. I mean, you have to invest. So we are weeks away from a 20,000 patient trial comparing that Shield test that has epigenomics to colonoscopy in the United States. That's a 9-figure investment that we've made, and so yeah, the bar is high. I think the challenge has sometimes not been how do we invest in clinical utility or clinical evidence, but that the bar is variable with all of the different health organizations. When you think about not just the U.S., but all of the EU5, every country, you have these different conversations that are there. Do you need a randomized control trial? Do you need this and that? And the bar keeps moving. So that has been the biggest challenge. Not that there's a bar, but that the bar has not been consistent. Yeah. Awesome. Okay. I could do it all day.
Thank you for the talk. I wanted to ask, when you talk about patient access, part of it is awareness and how many people know this is an option. I just wanted to hear your take on, is there enough awareness, and how can we build that awareness of this opportunity?
I would say that it depends on which area of the pie we're looking at in terms of the cancer patients. Certainly for screening, that is going to be a big part of essentially our efforts, is making that awareness there. I mean, doing digital media, all the different consumer channels, making sure that we inform patients that these options exist. With late-stage disease, it's been more challenging. It's really about educating the physicians, getting into guidelines, really about the care system, getting into electronic medical records, having things that are very frictionless. Just because late-stage disease is still very overwhelming for many patients. Even the name of the disease is difficult to pronounce, let alone the drugs. And so it's not as consumer-friendly in that part.
Okay. Super. Thank you.
Awesome. Thank you so much.
Excellent. So,
Awesome. Thank you. Thanks so much.